Previous conferences have featured a debate between Professor Alastair Greystoke and Dr. Tom Newsom-Davis, followed by a vote by yourselves. So, the first year was a debate about whether lorlatinib should be used as first-line treatment, and Professor Greystoke supported this proposition and was soundly defeated by 100% of the delegates at the time, yes, if I remember correctly, sorry. Yeah. Oh, it was only 99%, was it? Right, okay, fine. If that makes you feel better, okay. So, I'm not sure, though, if that debate was repeated today, the result would be the same. No. Perhaps we should debate that next year. We'll see. The second year, the debate was about treatment at local hospitals versus treatment at regional centres. And actually, the result was a dead heat. So, or to play for today. So I need to say that the positions, this in all seriousness, the positions taken by the two eminent oncologists are purely for debate purposes, and they do not represent their own views. So please, I need to make sure that everybody acknowledges that. So this year we're going to debate whether patients should have regular brain MRIs if they're not showing any symptoms. And at the end, again, we will have a show of hands. So let me introduce the two gentlemen. Professor Greystoke is an honorary medical oncologist at Newcastle's Northern Centre for Cancer Care, and Dr. Newsom-Davis is a consultant medical oncologist at Chelsea and Westminster Hospital. He's also chair of the British Thoracic Oncology Group Steering Committee. So BTOG is the UK's leading body for thoracic oncologists. Professor Greystoke is going to kick off the debate. So I'd like to welcome him here. Good luck.
So I just realised, Tom, given I'm on steering committee for BTOG, does that make you my boss? And do I have to leave? So what we're going to talk about today, so Tom and I came up with this idea for a potential debate a couple of months ago. So we're not going to talk about the issue about when patients first present with ALK lung cancer, about whether they should have an MRI or not, because we thought that's just good practice, that everyone should. But the question then is, well, if you do have that MRI or CT scan at baseline, we would advise an MRI, and you don't have any symptoms and you're established on your treatment, should you be going on to be having serial MRIs after that? And if so, how often? So I'm going to make the case for and going to win, and then Tom is going to make the case after and lose. So unfortunately, we do know that ALK lung cancer has this preponderance for the brain. And it has more of a preponderance for the brain than other forms of lung cancer, including some of the other oncogenes, such as EGFR. So this is a slide I sometimes show when I'm giving talks about precision medicine to show the importance of knowing a patient's genomic makeup to guide their care. And you can see, so on the left is a graph I made with some data from this paper that suggests about 1 in 3 patients with ALK lung cancer, if you do an MRI, you will find some evidence of brain metastasis. And you can see that is higher than the other types. And on the right, from the same paper that I took the figure directly from this, they looked at if you don't have brain metastases, if a patient doesn't have brain metastasis, each year that they are on treatment and the cancer is under control, so this is stage 4 lung cancer, without brain metastasis, how often do they develop brain metastasis? And again, unfortunately, ALK lung cancer is leading the way here with about 11 to 12% risk each year of developing brain metastasis in the absence of brain metastasis at the start. I will say that paper is getting a little bit old. It's from JTO 2023. So a lot of what they were looking back at would have been 6-7 years ago, where we were mainly using crizotinib, ceritinib, and maybe not using some of the more brain-penetrant ALK inhibitors. So I'll show you some data on. I don't think it's quite that high if you're on a decent brain drug, but it is still a significant issue. And just to show you how this can lead to problems, so this was a patient of mine, it's still a patient of mine actually, who was on a trial of ceritinib, so it shows how long I've been looking after him. And as part of that trial and as part of care, we did do imaging right at the beginning, but within the trial didn't ask us to do repeat MRIs because this trial was run many years ago, and most ALK lung cancer studies will now make you do repeat MRI scans. But about 4 years into treatment, he started complaining of headache, which had absolutely nothing at all to do with his cancer, but we did a repeat MRI. And the radiologist reported and said, well, I can see these little brain metastases here. You can see with my red arrows. But for us looking at these look really inactive. The radiologist said, you can see they almost look very pale, and you can see these sort of punched out dots, and they actually almost had little bits of calcium in. So the radiologist said, well, these are new from 4 years ago, but I don't know how long they've been here. They don't look particularly active. Have you changed this treatment during those 4 years? And I was like, no. So that led to a lot of issues, because then when I was talking to the clinical oncologists about whether we should give stereotactic radiotherapy, they said, well, what are we going to give it to? And so what we ended up with this guy was we ended up having to do serial MRIs over about 9 months to try and work out which of them were actually active and which ones we should target with our radiotherapy. So this is why you need to have serial ones, because if he'd been having serial ones and if he had been having the optimal care, I think you'll all agree we would have been able to pick these up early and pick them up at the appropriate time. So this is more up-to-date data looking at one of the newer ALK inhibitors, and you can see that if you don't have brain metastasis at presentation, you can see that most of the patients who progressed on this ALK inhibitor were progressing outside the CNS, but a significant proportion, about 10%, were progressing in the brain, and that was their primary site of progression. So if we hadn't been looking for it, we wouldn't have found it. Where are we now? Well, Deborah, I think you need to update this data, don't you, probably, but this is the report that you guys presented a couple of years ago in your survey, just asking patients how often they were being offered brain MRI scans, and you can see that the number who are getting them regularly is probably about 2/3, but with a wide variety, and most of these patients probably would have had brain metastasis at presentation. So I suspect the third that never got brain metastasis, most of those were patients that were not known to have brain metastasis. We do know it's better to pick stuff up early. So this is the ESMO guideline as to how we should treat ALK lung cancer. And you can see that we do need to be picking these up early, because if we've got what's called oligoprogression, so if we were just seeing 1 or 2 or maybe even more areas progressing in the brain, that we should, rather than be changing systemic treatment, we should probably be at least considering local treatment with stereotactic radiotherapy. This is, I think Tom's going to comment on the lack of evidence, but this is really good evidence. Looking at patients with brain metastasis, again, this is regardless of whether this is ALK lung cancer or not, but looking at the maximum size of the cancer in these patients when they presented either with asymptomatic disease, when it was on average about 1 centimetre, and when they presented with symptomatic disease, when on average it was about 3 centimetres. And also that impacted on how they did with subsequent treatment. So what they did is they looked at those patients who were asymptomatic and then went forward to have surgery or radiotherapy, and how many of them preserved their neurology, how many ran into problems subsequently with things like weakness or numbness. And you can see that if the patients were asymptomatic to start with, they were much less likely to run into problems with symptoms from their brain metastasis than if they presented with symptoms, even if they were treated, the symptomatic patients were treated appropriately with surgery. These are complicated. I hate these things. So these are what are called nomograms, where people do very complicated analysis to try and work out how we can predict patients who are going to do well. So this is a very recent paper. It's only a month or 2 old. And they were trying to look at how you could predict patients with brain metastasis, how they would do in terms of prognosis. And you can see that things that would predict better prognosis are on the left, and things that predict worse prognosis are on the right. So better prognosis is ALK, as compared to other genomic mutations. So we know that actually ALK patients that have brain metastasis will do better than patients that have other forms of lung cancer, and that's because we've got better treatments. But you can also see that picking it up early is important. So it says volume of the first treated SRS. So the earlier we pick these up and the smaller they are, the better the patient's prognosis. And also you can see if they have symptoms, they do worse. Okay? So very important in terms of prognosis that we pick up these cancers when they're small and when they are asymptomatic. Also, this is slightly more, so the other thing to say is this very interesting paper from 2008, it is old, and it's small numbers, but they looked at patients who were having chemotherapy for the brain metastasis when it wasn't really working. And they said how quickly were they growing when the chemotherapy wasn't working. And you can see on average, a brain metastasis increases by about 2% a day, and every 2 months will double in size. Okay, so if you're waiting for the symptoms to develop and you're waiting 2-3 months, then your cancer is going to be bigger. The other thing that we really worry about with stereotactic radiotherapy in terms of quality of life is the risk of radionecrosis. So that's dying brain tissue around the bits of it being treated with radiotherapy. And again, this is a paper where they tried to model this and said, well, what impacts your risk of developing radionecrosis? And the answer is the more brain you irradiate, the more likely you are to get radionecrosis. And it sort of makes sense. So again, the earlier we pick it up, the less likely we are to run into complications. It doesn't matter how many we treat, it's the volume we treat, okay? So if people sort of used to wonder, oh, is it 1, 2, 3? But it's all about volume now, okay? So picking up smaller allows more treatments. And actually on the right, you can see that patients do equally well if you treat them the first, second time. Yes, the third time with stereotactic radiotherapy, it may do slightly less well, but we can do multiple treatments on multiple brain metastases now, so it's important to catch this earlier. Last point is that we know in terms of drugs, the brain is different from the rest of the body. So this was a really key paper written by Ross Camage, a friend who many of you may be aware is going through his own cancer journey at the moment. But he set out at this time how we should do drug development in the brain, and accepting that it is a very different place than the rest of the body and that we need to design drugs separately. And it's in international guidelines. The Germans are way ahead of us here. The Germans have structured guidelines, which we don't really have in the UK. And you can see in there, they say that a structured examination should be offered every 3 to 6 months to asymptomatic patients. And this paper was published in 2018 that said, well, you need to treat the brain differently in ALK lung cancer. And they commented at that point about monitoring asymptomatic patients. And so I counted since 2018, 5 prime ministers, 6 deputy prime ministers, 7 chancellors of exchequer, and we still haven't moved on. So I'd be very interested to hear how Tom thinks we should stay as we are. Over to him.
Afternoon. First thing to say is that England ladies are 7-5 up after 10 minutes. It's good news. Canada scored first, but quick reply, so it's good. Okay, so hello everyone. I'm Tom. I'm going to kind of argue and, in fact, demonstrate why actually CNS surveillance is not the way forward. Bit of a personal story here. So a couple of weeks ago, I came off my bike on the way home from work, during the tube strike, actually. And although the A&E department I went to, my own A&E department, said I was fine, transpired I actually broke my pelvis in 2 places. Here I am, giving a talk, calm, a bit like Maggie Thatcher after the Brighton bombing, right? Why am I here? Why have I dragged myself off my sickbed? Is to prevent scurrilous nonsense that you just heard. Yeah? I couldn't let it lie. I couldn't just sit there. So, obviously, severe pain and can hardly manage, but that's how seriously I take this. So, here are my disclosures. I was thinking when I was writing this, why would we do brain surveillance? And I thought there were 2 reasons, and only 2 reasons. One of which is to make someone live longer and or make someone live better. And if you're not going to do that, there's no point doing a scan. We don't want them just for decoration. Unless we're making people feel better and or we're making them live longer, don't do it. And I think that's the principle behind every kind of surveillance. So what does a normal brain scan tell us? That is a normal brain scan. It tells us that at that point, that person doesn't have a brain metastasis. It tells us also that they don't have a brain metastasis tomorrow. And they definitely don't have one next week. And they probably don't have one next month. But a month after that, as we've just seen, doubling time 58 days. So it tells us a short period that things are okay. Single brain scan does not give us 6 months of guarantees or a year of guarantees. So if we're going to be doing scans, we need to make sure we're doing them very frequently. So my first argument against would be anyone who's doing brain scans annually, waste of time. 6 monthly, waste of time. 4 monthly, probably a waste of time. So you've got to do them more frequently. Now, let's get on to that data. Let's look at the data on the evidence that a brain scan improves survival. Oh, it hasn't projected very well. So I've just... Oh, there isn't any evidence. Absolutely no evidence that doing scans will make anyone live longer. Now, you can look at surrogate markers, you can put nomograms up, and you can put all sorts of stuff. But in the end, can anyone show that doing a scan has made anyone live longer when doing surveillance for ALK positive, or in fact other mutation-driven lung cancers? None. But it's not all about survival, I absolutely agree. So don't make light of that. And it is also about quality of life and symptoms. So let's look at the data on quality of life. Do you know what's going to come next? There's no evidence. Absolutely none. There's nothing to say by doing a scan you actually make people feel better, you reassure them, you improve quality of life, you reduce anxiety. None at all. So if you're going to do it, you're doing it without any evidence of benefit. What do the guidelines say? There was a German guideline. I don't think we need to listen to the Germans about these things. They're outrageous. It's not very British, is it? We have, however, got the ESMO guidelines, European guidelines, the American guidelines, NCCN, this extraordinary explosion of colour called the European Association of Neuro-Oncology. None of these guys recommend surveillance, not one, not in their guidelines. Now, these are independent guidelines written by the good and the great. None of them say, in the treatment of mutation-driven lung cancer, should there be routine surveillance. So why are we doing it? What about the trials? What do the trials do? Well, actually, this is tiny. It's so tiny. I'm so sorry. But what this is trying to show, I couldn't get it into a bigger picture, so I didn't bother rewriting it. Most ALK trials in the first line did not include routine MRI surveillance. Now, some did CT. That's a waste of time. No point doing that. Can't see what you're looking at. But very few did routine MRI. In fact, it's only the three at the bottom, which was Crown, first line Lawler, brigatinib, Alta L1, and alectinib, not the ALEX, but the Alastair trial, did. So actually, most of the data we have and most of the benefit of the drugs we talk about and we use day to day, including ALEX, did not include routine MRI surveillance. So it's not like everyone's been doing it for donkey's years and we're not and it's weird. Even in the trials, it wasn't done. But more importantly, with the advent of drugs that really work, do we really need it? So this is first-line lorlatinib. I mean, I'm an oncologist. I can't do a talk without a Kaplan-Meier curve. I get very scared. This is looking at percentage of patients without the cancer getting worse in the brain. Okay, that's what we're looking at. At the top, no one's cancer has got worse in the brain, and at the bottom, everyone's has. And the two lines on the top is the blue, which is patients on lorlatinib, and then the red are patients who are on crizotinib. If you're on the lorlatinib, the blue line is right the way to the top, all the way to 60 months, 5 years, and in fact beyond. And what that says is there is an incredible prevention of any involvement of the brain. Things getting worse in the brain. 92% of patients, 92% at 5 years hasn't got worse. So if it's that good, why are we doing scans? It's a waste of time. It's such an effective drug. Are we really good use of time, resources, and all those things to do that? So you might say, well, okay, fair enough, but why do it anyway? Oh, what's the harm? What's the harm of a brain scan? Well, actually, it's quite a bit of harm of a brain scan. I've had lots of brain scans. I had a scan for my life-threatening pelvic injury. I actually fell asleep in it. It's extraordinary. I found it very calming. But lots of people do not find it calming. Anyone who has any degree of claustrophobia, the prospect of an MRI is terrifying. So claustrophobia can affect up to 40% of people going for a scan. It can actually prevent scan completion or get a poor quality scan because you just can't keep still. Anyone here claustrophobic in MRI scanner? And it can impact on quality of life. For years, I've had people saying, I just don't want the scan. So although there is no radiation, it's a magnetic scan, obviously, there is that. And then you've got scanxiety, which everyone kind of jokes about because it sounds like a bit of a funny pun, but it's really unfunny. And the anxiety that scans produce is very real. And there's some really interesting work on this and data on this, looking at the impact of scanxiety, the psychological impact on people, the long-term complications of it, effect on mental health. And it's well recognized that the scan itself is a precipitator of scanxiety. And although the results can, obviously then one feels more relaxed afterwards, your next scan is coming up. So when you're doing the routine scans, an unintended consequence of that is scanxiety. And it's already difficult enough with the routine CT scans for the rest of the body, but the brain is an additional anxiety. So that's one issue. The other issue is driving. Now, you've just been hearing about the various rules. If your brain scan says you cannot, you have a brain metastasis, the immediate response to DVLA is going to be you can't drive. Now, there are ways of getting that back, and you've heard about that. It's a bit of a lottery, frankly. And if you live in central London, like I do, that's not a major issue. I can get on the tube. If you live where Ali does, in somewhere up north, there is no tube. Don't even have a car, do you? Horse and wagon. So, you know, it's huge impact because you can't get anywhere. And that's a huge loss of liberty. If you work, it's going to make work very different. If you have family life and your kids are dependently driven to school, it's a nightmare. So actually it's a big impact for something you maybe didn't need to know about. And remember, the scan will not have any evidence to improve survival or quality of life. VOMIT. VOMIT is an acronym for Victim of Modern Imaging Technology. In other words, someone's done a test, they've done a scan, and there's an unintended consequence of that. And one unintended consequence, one VOMIT of brain scanning is you may get radiotherapy that you didn't need. You pick up something tiny, minuscule, goes to the team say, oh, it looks like a metastasis to me. You go and have your gamma knife or your stereotactic radiotherapy or your cyber knife, and you have a treatment you don't need. Over-treatment. Maybe you never needed to have that treatment. Maybe that was never going to do anything. It was going to sit benign and not do anything, as Ali suggested in the case he showed you. Maybe that never was going to cause a problem, and you've irradiated something you don't need. As Ali's just shown you, I'm surprised you've dynamited your own argument. It's terrible. As he showed you, if you have stereotactic radiotherapy, you can have things like radionecrosis. So there is a risk of overdiagnosis and overtreatment. So, CNS surveillance, it's a lovely idea, okay? It sounds great. It's like we should have screening for everything. And on the face of it, it's a no-brainer, no pun intended. But actually, there's no evidence it helps. It's not recommended in any international clinical guideline anywhere. It can unintentionally impact on quality of life. It can result in overtreatment. So what's my view? I don't think it should be mandated. Because if you mandate something, you create trouble and you get terrible trouble. You're not doing it, you feel having the wrong treatment. In the absence of symptoms and the absence of any baseline metastases, as Ali said, this is people who we know do not have brain metastases at baseline and have no symptoms. I think it should be discussed and agreed at an individual level. If someone says, I really want to have this, then it's reasonable. But I don't think it should be mandated as a routine thing. I'm just going to go back to my wheelchair because obviously I'm in terrible pain. Sympathy is what I'm after. Thank you very much.
Well, thank you very much indeed,
Could I
both
make
of
a
you.
point about his last point?
Yes.
So he's been hopelessly naive. So Tom has worked in the NHS for about many years. Something's not in the guidelines and you start ordering an MRI on a patient every 3 months in the NHS. Are you going to get those MRIs?
I'm sure I will.
Okay. Oh yeah, he's got the gift of the gab, doesn't he? Yeah.
Yeah. Right, so before I'm sure people will have questions, I am going to put the vote out to the room. So can I have a show of hands for all those that support Alastair's position in terms of to scan is better? So can I just see? Oh.
It's not looking good.
Okay, and let's just be fair. Can I have a show of hands for those that support Tom's argument not to scan?
Hey, the enlightened people.
I think Alastair's won. So So, on to the important bit, because I know there's going to be questions for you too. Now, we are on a tight deadline. Both gentlemen, unfortunately, do have to leave us by 5 o'clock, absolutely. So we need to make the most of this time with them. So, does anyone have any questions? Oh, yes, straight away. There's a surprise.
Hello, Tom.
Hello.
My doctor. Have you seen are there studies that says there is no evidence that the surveillance works? So have you seen and read these studies, and how are they done, and are they convincing?
Yeah. Obviously, you cherry-pick the data for the debate, and there is no evidence, but that's not because there's evidence saying it doesn't work. It's just no one has done the study, and they will be ongoing. And it's a very difficult thing to do. Yeah. So the fact there is no data is not because someone has looked and said it doesn't work. It's because no one's done the studies and they're complicated to do.
Yeah, you know,
very good point.
I think it would be very difficult to do a study like that. You know, even to have the. So when we do any study, you like to have equipoise. You know, yeah, I go to a study and say, I think this is a good study for you. But you know, particularly something like that, where you're asking a question and you shouldn't really know the answer before you do it, and we don't. But I think that would be. I agree. I think
it'd be hard to get people to enter that study because the study was we're either going to do scans or not. I think most people would say, well, that sounds like a terrible study. Yeah. So I don't think it will ever happen.
And sorry, just quickly, comparing between countries that have different policies could work.
It's a nice idea. I think there's such a variation in every other demographic type of treatment that I think it will be something we'll never get good prospective data, in other words, data going forward. I think there may be some studies in the years to come saying we've looked back and we've found in the places who did more scans, people lived longer and lived better, but that might just be because they had better doctors.
You know, the other thing to say, and I'm surprised Tom didn't bring it up in his discussion because it's an easy point, is that the UK is very lacking in MRI scanners. So compared to Japan, we have about an eighth of the number of MRI scanners. And that then also leads to issues with reporting. So, you know, certainly I often wait 4-6 weeks for reports, which is an absolute nightmare because I'm very actually happy generally interpreting CT scans. But MRI brains, you get about 1,000 pictures. They do different reconstructions. I don't even understand the acronyms they use, never mind trying to interpret them myself.
Yeah, I think it's a really good point. And I think we shouldn't ever allow what we can do to impact on what we think we should do. But it is a really good point that MRIs, waiting lists are so long because they take so long to do. An MRI of a brain takes, you know, by the time you're in out, probably half an hour to 45 minutes. A CT of your head takes 35 seconds. It's incredibly quick. And then the reporting. And I think we have massively underinvested in radiology. It's actually not so much doing the scan, it's actually the radiologist. They're just not enough to report them. So if you had your scan, it may not be reported. That being said, with my caveat, we do routine MRI scans in our practice. I do 2 hospitals. My nearest one is the West Middlesex, which is just down the road. And with a bit of planning, we can get routine MRIs. I can't get them every 3 months, but we can get them about every 4 to 6 months. But then it's another 2 months to get it reported.
There's a question over here.
Yeah. I think I was just curious to see your point of view on some oncology consultants state that there's no need for frequent brain MRIs because they grow so slowly. With the ALK mutation, they grow so slowly. And even when a patient starts to present some symptoms, because the growth is so slow, they're not needing the MRIs if they're asymptomatic. I know that's an argument that was put forward from our consultant, and I was just curious to see what your thoughts were on that.
So I guess the short answer is we don't really know. You know, that data I showed was in 2008 when it was on chemotherapy. I guess mostly in clinical practice they do grow relatively slowly, but I have had some patients who have presented really quite rapidly with quite nasty CNS disease. And depending on where it is, it can cause symptoms very quickly, you know, if it's in the bottom of the brain where, you know, everything's quite tight together. So I think there's a reasonable point for not doing surveillance. You know, I think Tom's right, there is. I'm not sure that's the right argument for me. You know, I think the argument, the Crown data is very persuasive that, you know, if you have your baseline MRI, 2-3 patients in that study in 6 years developed brain metastasis. So I think that's a more relevant one. Whether that's the same for, if you're going to start brigatinib or alectinib, it's probably not quite so good. There you do get them, not as quickly as the 1 in 8 a year I used, but you do get them. Tom, do you want to?
Yeah, I think that's right. I don't think that's an argument for not doing it. I think it could be an argument for doing the scan less frequently. I think you could say, okay, maybe you don't need it every 3 months, and I can't get it every 3 months anyway.
Yeah.
But I don't think I would see ALK as a lung cancer where I would, by definition, think a brain metastasis would grow slowly. So with the greatest respect to my learned colleague, I probably wouldn't agree with that.
Yeah.
Anybody else? Oh, there's a question over here.
Do you think there is any chance that there is a bit of a postcode lottery with regard to the cost of MRI scans? Because, my particular oncologist had said, unless you're showing any signs, we won't. But I have persuaded them to do an MRI scan, but it's a year since I was diagnosed. So do you think there's anything to do with finance?
It shouldn't be different in that when we request a scan, it doesn't come out of our budget. There are some things you have to get particular funding for. The drugs, high-cost drugs, we have to do a particular funding request. A lot of people for PET scans, because they're often not in your own hospital, ours aren't, they're down the road, we have to get a little bit more caution. But actually an MRI scan, our orthopedic friends are doing every 30 seconds for someone with knee pain. So I don't see that as an argument. Actually, scans are pretty cheap once the machine's there. So I think there's a postcode lottery in terms of practice of what people do, but I don't think money is the justification.
And I think, guidelines may be the way to get around the postcode lottery. And this is an issue, is that we don't have guidelines. But I think this would be a difficult area to have guidelines, because I think Tom's probably right, or very lost, that this should be an individual, discussion. But as I said, the problem is if you have an individual discussion, then as a clinician, you go to the MRI guy. And so what does have to happen is if I request an MRI scan, it will be vetted by a vetted by a radiologist. So he has to give a tick. And actually, I don't normally get pushback, but there can be pains and just say, no, where's your evidence, where's your guideline that says you should be doing this?
Yeah, that's a really good point. And I think there are hospitals where there is a culture of we will or will not do that. And I think if you're the consultant requesting it and you're going to get a shirty email from one of the radiologists saying, why do you keep requesting that? You're going to kind of take that view. And I agree. I think if we had evidence and guidelines to say this is what we should be doing it. One catch about a guideline, if you say, okay, everyone, we should be doing MRI scans every 3 months, for argument's sake. If you can't do that because your hospital just isn't kitted out, then you find yourself on the wrong side of recommendations, and it then suggests you're giving bad practice, which is not a great position to put people in.
Okay, this question over here.
Tom, can I ask you, I thought I heard you say that in the Crown trial, they didn't do MRI head scans, and then
The Crown they did.
Crown they did?
Yeah, Crown they did, yeah.
Right.
So Crown and Alta 1L and one of the elective ones.
Okay. The other point which I think has been made, of course, the majority of patients in this room are not on alectinib. Sorry, not on olatinib.
Correct.
Yeah.
So
I was glossing over that point.
Yes, that 92% doesn't apply to the people in this room.
Yeah.
But, alectinib and brigatinib are both very potent CNS drugs. They are probably not as potent as lorlatinib, both for better and for worse. The worst is that you do sometimes see brain metastasis coming on, but also then you get the CNS side effects of lorlatinib that I'm sure you're all aware of.
But I guess the other thing is, going forward, we would hope that funding situation would change, and we hope going forward that the next generation of ALK inhibitors will have equally good penetration. So I think it's recognised for a long time now the importance of having drugs that work on the brain and developing agents that will have that. So we should be positive that we'll have drugs of increasingly good brain penetrance.
Oh yeah. So if you had two people, one has a scan every year and another does not, and they both develop metastasis in their brain, which one is better off? The first person who has the scans or the second person who does not? In the longer term, in terms of the sort of medium to long term, which one of those people are better off, the first or the second?
Yeah, I think that's a real crux. And I think logically you would say, well, it must be the guy who's had the scan done because they've had the radiotherapy. If we infer from a different tumour type, so EGFR mutated lung cancer, treated by a drug called osimertinib, which has got very good brain penetration, there has been some data looking at patients who've had stereotactic radiotherapy versus those who didn't, and there was no difference in overall survival. So you might, logically we would say, okay, it must be better to catch up because you can do the radiotherapy on the low volume disease, as Ali suggests, and cause no problems. But the truth is we don't know. And that's why although I was arguing against the point that I do, I think one thing which I do believe strongly is if you're going to do the brain imaging, you've just got to talk about the pros and cons. We will do it. This may be a benefit, but I don't know if it's going to actually make people live longer. Do you see differently?
No, I completely agree. We just don't know. It feels like it's the person who's having the MRI should do better because it's picked up earlier and smaller and stuff like that. But I think we don't know. The number of times I've thought something should be right and I've been wrong is lots.
And I think the important thing there is if there are people in the audience where you're getting pushback and you're not having the brain scans, and despite your best efforts, you're not getting the MRI that you want, I guess one reassurance might be, well, we don't actually know whether you're at disadvantage, because you may well not be.
Yeah.
This one question over here.
So, are there any patient registries in the UK which record what percentage of patients get brain mets?
No. We have done a few ALK registries as academics in the past, led by Fabio Gomez at the Christie, and we did capture brain metastasis at that in that registry. But no, we don't have very upfront registries. I'd be very supportive of patient power in this situation. You guys coming together to get your own registries as to how you present if you have brain metastasis at presentation or not, because actually as a busy clinician I don't really have the time to do it. Things like resistance mechanisms, I'm very in favour that this is something I think we should see coming forward.
Can I just then give a plug to the organisation? We already have set up a register on the
There you
website.
go, perfect.
So we would encourage every one of you to register. A number of you have, so please do. And there you've heard it from
it'd
the boss.
be incredibly useful,
Yeah.
because your data is, and it's actually probably more accurate than one of my clinical fellows who doesn't really understand ALK lung cancer trying to go through your notes and trying to work out what's going on.
Okay.
And just to add to that, it may be seen incredulous, the NHS doesn't know that. And actually, the NHS has more data on its patients than almost any other organisation in the world. I mean, we're way ahead. We're very good at counting things.
Yeah.
Good doing anything about it. We're very good at
count.
counting things. The way that NHS gets its data is when anyone has any cancer diagnosis, it goes through an MDT, and that MDT is recorded on an electronic form, and all those electronic data are uploaded to a central server where this stuff is brought out. It will record the stage 1, stage 2, stage 3, stage 4, but it won't put in every single area of disease because there just isn't the capacity to put that data in. We have done real world studies, and Adi mentioned Fabio, who's done that. Those are often not so representative because they tend to be a coalition of the willing. You email 150 oncologists and say, right guys, who's going to help do this? And you might get half of them replying, which is not very, you're lucky, and which is not very scientific. And of course, you often tend to get the more engaged and more involved centres being replying, and therefore they're probably more likely to do brain scans. You're probably getting an overrepresentation. So I think if you guys are doing that, it will also not be that representative, but it will be brilliant, and we would fully support that.
So just a quick point and then a question. The point, even though I've voted for Alastair, Tom, you could have also mentioned false positives, which do happen quite a lot. I've certainly suffered from that. I had a false positive and went through 2 months of worry and concern about having a brain met, which turned out to be an artifact of the scanner.
Yeah.
And was
And that was sort of the vomit thing I didn't include. Yeah, it might be, and then we just scare the pants off you. But yeah, it's a very good point.
And then my question was we're already seeing the utilisation, but the issue with availability of radiographers, we're already seeing that being partly addressed in the X-ray space and to some degree in the CT space as well, with the use of AI for prioritisation. Mm-hmm. Is that going to happen with MRs? Is that happening with MRs as well?
Yes, is the short answer, but I think it is a bit more complicated because there's a lot of pictures and it can be complicated, and people's brains do differ more, particularly on a one-off scan. When you're doing serial scans, it's a bit easier, but yeah, there are definitely a number of AI tools out there to help people report MRIs, and I agree, I think that will help. The other thing I just wanted to say in terms of the false positives, something that come across all the time, if you have had stereotactic radiotherapy and your scan gets reported by somebody who hasn't seen a brain that has had stereotactic radiotherapy, they will often report it wrong because they look very different. So the number of times I've had patients who've had stereotactic radiotherapy in Newcastle and have gone and had a scan in Hexham, which is where I live, 50 miles down the road, very beautiful, and the radiologist says, oh my God, they've got progressive cancer, and you take it back to the stereotactic people and say, no, that's just what it should look like. Okay.
Just one thing to say about the AI definitely coming. So there's already companies doing that. They actually cut their teeth in predicting the evolution of strokes. They did that on CT and then MRI. We hope to include a session on AI in our BTOG 26 meeting because it's such an important thing. There's AI in follow-up of patients, but there's definitely AI in diagnostics. Probably it's most useful is saying what looks normal. They'll say, that's normal, don't worry about that. Yeah. And then say to the radiologist, can you focus on not on the 10 normal scans, but on the 5 maybe abnormal ones. We've got the beginnings of AI in chest x-rays in a hospital ready at Chelsea. It can be helpful. It can be hilariously inaccurate sometimes. But it is quite good at saying, that's a normal chest x-ray, don't worry about it.
Okay. This question at the back of the room there, and then...
Okay. The accepted advice is to stay on your TKI for as long as possible, but you've mentioned that alectinib is not as effective with brain metastases. If you're asymptomatic, but your career depends on you not having any evidence of brain metastases, and if you do have any, you will never work again, should you be pushing to move on to lorlatinib?
That's a really good question. The question about, should you change? We get asked this all the time. Should you jump ship when your cancer hasn't progressed? And I think the short answer to that is that I don't know. Lorlatinib is not the easiest of drugs, and could have an additional side effect that might then impact on your job. If you had a neuropathy or if you had a mood disturbance. So in general, I wouldn't advise it, but I can certainly understand the argument, and I'd be more than willing to have that discussion with a patient. I would then have to lie on the NHS form, but that's... Are we being recorded? That's fine. But yeah, I think in general, I am reluctant to jump ship, when you're on a treatment that is working, because it's sort of a better the devil you know type approach.
Yeah, I agree. I think it's really hard. You can absolutely see the rationale behind it. I guess whether a brain metastasis appears is partly a product of drug, but it's also predominantly a product of tumour biology, and you don't know whether that particular tumour is going to do that. I think if it was something that was paramount importance and someone was asking that, I think you'd have to entertain it and misread the blue tech form by mistake.
Click the wrong box.
Or you could maybe find a spec somewhere in the scan and say, well, clearly the disease has got worse, and then you click on the button saying things have got worse. Not that I'd ever advocate doing that in any form at all.
But there's a very good point. So we're likely to get, I think we will get first line lorlatinib in the next few weeks. I'm optimistic, so nice rules are that if you started lorlatinib in the first 3 months, and you had a side effect, you will be able to swap back to alectinib and brigatinib. If we sign a form saying that you've progressed on alectinib, and we're changing over to lorlatinib, you would not then be able to go back to alectinib. Okay, so there's some quirks around the funding rules. So yeah, you'd have to be very careful about that.
Okay, good question here.
Hi. My question is more for those of us on second-gen therapies, we know the likelihood of progressing the brain as a possibility, say we do, we're often given the choice between radiation or going for the next drug, lorlatinib. Do you have a preference? Because people often say they want to stay on their first TKI for as long as possible. Obviously, if it's controlling the body, then would you just move for the brain? You know, what's your view on that? And then I have a similar question. I know we're talking brain, but if you don't mind answering about the bones as well. So if you progress in the bones, would you view that differently? Would you radiate the bones or move to lorlatinib? So, two-part question.
So in terms of the first one, yes, if it's one or two areas, I will try and persevere, you know, and my team understand that's the appropriate thing to do. And that's sort of what the ESMO guidelines I showed suggested. You know, I think but eventually we do sometimes say, well, actually, yes, we can irradiate, but we're getting right up to the volume, or we're a little bit worried about leptomeningeal disease and that we might not be able to get control of radiotherapy, and now's the time to change. And I'm very comfortable about that because lorlatinib has very good, it can regain control in the brain. In my experience, it doesn't do so well in the bone. Lorlatinib's not as good as regaining control. If you're getting extracranial progression, it definitely can do it, but it's not as good at doing that. And bones can often cause problems, and radiotherapy to bones causes relatively little in the way of problems. You know, you don't have issues about radionecrosis. So, yeah, I'd probably go for radiotherapy there first rather than the change. The only slight issues that the radiotherapy we give in the NHS is probably not the best radiotherapy. We're not yet giving stereotactic.
I think it depends. I agree with that. I think it depends a little bit on the context of those brain metastases. If someone is entirely well, low volume, small number, I would definitely try to keep someone on the first-line drug. I'm a great believer that is, you know, I think it is an easier drug than lorlatinib. Conversely, if actually the scan is showing multiple areas and the brain MDT is saying, well, look, we can do it, but there's a lot going on, then you may want to switch. We should remember, I agree with that the duration of lorlatinib as a relapse setting is not as good as first-line drugs. It's not probably, I'm afraid, going to give the same period of control. So if I can keep someone on a first-line drug and my clinical oncology colleagues say they can do the stereotactic radiotherapy, we stick with that. We're quite lucky in West London. We've got a very good unit out of West London which does all the gamma knife and cyber knife and other things involving the word knife. That's what I would probably do.
LMD, sorry, I lost one, but LMD, is there a connection between radiation and leptomeningeal?
No, it's just...
So the question was, is there a relationship between LMD and stereotactic radiotherapy?
Yeah.
Yep.
And so the answer to that is no. So it doesn't cause it. It's just if you've got leptomeningeal disease, which is involvement in the membranes of the brain, it is likely there's going to be cancer cells in the fluid that is running up and down between that. So just irradiating the bit that you can see on the scan, and it's often very difficult to see on scans, even with MRI scans, is unlikely to be beneficial, whilst drugs can actually work very well for leptomeningeal disease, although not as well for other brain metastasis. Unfortunately, this is one area where we really need better treatments, is leptomeningeal disease.
So, oh, there's a question here. Sorry.
Oh, sorry. Yeah, thank you. I was interested to see the point on unnecessary SRS and unnecessary radiation. Is there a way to predict when things pop up in the brain whether or not you should be radiating them? You know, if they're particularly small?
There isn't a particular way, but a good unit, as we said in the corner, will actually nearly always say, I'm labour the point, obviously, you know, I'm not sure, we'll repeat your scan in a couple of months' time. And that's always an awful 2 months, obviously. Yeah. But it's a very good way of doing it, because if something has gone away or hasn't changed, then I'll leave it alone. And looking at the notes from my neuro-oncology colleagues, so frequently they're just repeating a scan in 3 months to see what it shows, and you normally know. But Ali made a really, really good point, that if someone's had a scan reported locally by a not expert neuro-oncologist who didn't know about the radiation, they'll say something which often is not relevant. It goes back to central MDT and they say, oh, don't worry about it, it's fine. Yeah. So always make sure that the original treating team have had a look at the scan before jumping to conclusions.
Thank you.
Okay, I think we've exhausted all the questions.
Exhausted
no,
me.
There's not. There's one there with the pink shirt. Here.
Maybe a bit off subject, but you were talking a little bit about moving from alectinib to lorlatinib as a first-line treatment. Really, do you have a view of the length of time where you'd get the benefits of lorlatinib still as a first-line treatment? You know.
Say that again.
Well, if you move from alectinib to yeah, thank you. The chart you showed was with as a first line treatment.
Yeah.
Right. If you're moving from alectinib, do you still get the benefit if you haven't progressed at all? Do you still get the benefits?
No, okay, that's a good point. You haven't progressed. So we did some real world data, which we showed a couple of years ago in BTOG, and that showed if you, on a first line ALK inhibitor, you go on to second line lorlatinib, the average duration is 5.5 months. For people who had progressed, now if you're switching whilst it's controlled, I don't think you know the answer to that. It's a really good question. I think you'll have a much longer duration. I'm not suggesting everyone start switching, but I think you would, because it has not yet become resistant. I don't think you know the number.
No, we don't know. And so most of the trials for lorlatinib in the second line setting were for patients who had progressed on 1, 2, sometimes even 3 ALK inhibitors, so the biology is completely different. So, yeah, you know, I don't think we know. Well, no, we definitely don't know. You had to be progressing to go on to the lorlatinib. So that switch. There have been sort of studies in other spaces where they've looked at trying to interweave different TKIs. So the EGFR space, there was like a trial where they switched from afatinib to osimertinib and back again to see if you could stop the resistance mechanisms developing, because you've got different resistance mechanisms. It didn't work. It was a good idea.
Thanks.
Okay. Well, I'd like to thank both gentlemen for their time today and their time before today, because it takes time to put these presentations together. So,
and I lost.
A bit late.
Sorry?
And I lost. It's really
And you
interesting.
lost, yeah.
I
And
don't know why I
I mean, I
bothered.
can't believe you didn't vote for him, but he's got 2 broken pelvic bones. I mean,
Thanks a lot.
What do you have to do?
That's a real loss, isn't it? Let's be honest, folks.
To be fair, the first one that I lost, I could not sit down. I couldn't travel because I'd thrown a disc in my back.
Oh,
so,
yeah, that's true. That's true.
and I lost that one, so,
yeah,
you know.
did. That's
Yeah.
true.
You should have won it.
Yeah. So, as you can see, they're not competitive at all. So I'd just like to say thank you very much indeed. So it's always, you know, not just entertaining, but really informative listening to you guys. And so, yeah, and I know that everyone here today feels the same way. So thank you.